think we would, with this, move on to the next talk by Dr. Savitri Sharma, and she's going to be talking about microbiological and operating room protocols for endophthalmitis prophylaxis.
Good morning, everybody. Again, I thank AIOS and CIPLA for this opportunity. CIPLA relationship I have since long. They had sponsored a webinar way back when webinars were not so common, and that was first for me. And interestingly, the topic was also similar. So I hope I'll do justice to this topic and it will be useful to the listeners. I would like to echo what Arup said during our discussion that intracameral prophylaxis uh, cannot be the first line of prophylaxis. It comes after all the other things are in place in the operating room and for the patient. So, with this, I'll share my screen. Is that visible?
Yes, ma'am. Yes,
All
ma'am.
All right. So my topic is microbiological and operating room protocols. Everything has to be in place, and only then the talk about intracameral prophylaxis. I have no financial disclosures to make. Acute cataract surgery endophthalmitis is what we are talking about. There is no doubt is a very, very devastating condition, and the visual outcomes are often poor, so we are all worried about it. And it remains the prophylaxis remains a global imperative because of the increase in numbers. And despite the advances in surgical techniques, the incidence is not zero. It remains zero point zero 0.01, maybe zero point zero 0.01 it will become, but it's unlikely to be zero. From 10% in 19th century that it has come down to zero point zero 0.01 is quite an achievement for us. And all that is attributed to aseptic surgical protocols. Perioperative povidone iodine is the biggest thing that we can hang on to and forever. Isolation of eyelids and eyelashes, proper draping, topical perioperative antibiotics we just talked about. It may be doubtful, but we are not confident enough to give it up. And now, of course, the intracameral antibiotics is what we have come to. But incidence of surgical infection doesn't depend only on one thing. It is multifactorial. As you can see here, everything matters. And it is a human element which matters the most because people can make mistakes. Less For the benefit of general ophthalmologists, I came to know that more than 500 people have logged in. So I am sure the information will be useful to some that when you build a new OR, have it on upper floors, not facing busy roads, and avoid human traffic. The kind of walls, floors, doors that you make should have minimum joints and all electrical fittings should be inside. Color should be such that dirt can be seen easily. And I give emphasis on reducing ledges and gaps. Ledges are on the wall. It should be a smooth. The corner should be smooth and not have a niche there for the dirt to settle, which will invite insects. And nowadays, we have very good companies which come to our rescue for building good ORs, and that controls everything: temperature, humidity, noise, and ventilation. A few words about ventilation. Ordinary air conditioners, split air conditioners may be better than window, but normally they are not useful. And people would like to have filters in their ORs to downgrading from 10 micrometer size, pore size to 5, and then ultimately to HEPA filters, which is high efficiency particle arrestor filters of zero point 0.3 micron size, which filters out most of the fungi and bacteria. And volume exchanges are important. Positive pressure is important. And nowadays, it's quite common to see modular ORs in most of the places. Formalin, if at all some people are using, is actually not recommended because of its being a potential carcinogen, and the smell just gives a false security. It's not really required. People have seen in studies that controlled air circulation is as effective as using formalin, so there is not necessary to use formalin. And the usual way the filtered air that comes is from the ceiling and from the lower down of the wall, it goes out. So inlet and outlet of these HEPA filters is what I'm trying to show here. But places where we have secondary centers and we do not have HEPA filters there, but there is an option of having a overhanging HEPA filter, which is, I think, 4 into 2 feet in dimensions, and that can be hung just above the head of the patient, and that can give a laminar flow of filtered air. When we go to the protocols in the OR, we did talk about the mask. There is no doubt that all parts of the OR, actually, I'm trying to show that even in the CSSD, where you are just sealing packages and cutting packages, you need to have mask and cap at all time, and it is not optional at all. We did talk about the pre-op preparation and the beauty and benefits of betaine. We do not use 10%. I think that was mentioned, though it is recommended. We make do with the 5% betaine, applying it repeatedly, and it is, of course, it is put inside the conjunctiva. Training is very, very important, especially institutions where we have a flow of turnover of people. It's very important to train constantly. And even the older staff, I have seen that very senior nurses, they become very lax about what they do, take it for granted. We need to train them as well. And training in surgical scrubbing procedures. There was one time I have purposely put here not Bactolin. One of the constituents which a company was selling was Bactolin, and they were even recommending that for scrubbing. That came to our notice when in our secondary centers we found that the scrub areas were having Bactolin. This is definitely not recommended. It is just like any liquid soap. What we need and recommend is 7.5% beta. The percentage is different here. And of course, chlorhexidine. Post scrubbing, wiping hands, we give good training to people to do that using two ends of the cloth for the two hands and applying sterilium after wiping, and allowing the sterilium to dry on the hands is very important. Again, gloving is another one which is taken for granted and we think everybody knows it, but it needs to be emphasized and trained. People have to be trained all the time to do it correctly. There are many no's. I think all of us know that a gloved hand or a gown should just the anterior or the front portion should be completely protected and should never be touched in any way. This may be a little busy slide and everything is not important probably, but after each patient, there is a controversy about this. And I think we differ from Arvind in this, that after each patient, we actually follow the cleaning of the floor and the trash and changing of gown and everything is done. Uh, After each patient also, of course, OR tabletop and the instrument stands and other things are optional. What do we use for cleaning? I'm often asked. Sometimes my office will get filled with all kinds of chemicals kept on my table to check. We cannot really check whether a chemical is good or not. Every chemical that comes, it has to be judged by the content that it has. And earlier on, we were using basilocin, which had glutaraldehyde and formaldehyde. But now we have switched over to quaternary ammonium compounds, and this is D125, which may be a little bit more expensive than recently another product came, which is also quaternary ammonium compound. It is P125. So across our campuses, we have shifted to this, which can be used for cleaning as well as for fogging if you like to do. Our environment must constantly be cleaned as much as possible, including the instruments, equipment, and etiquette must be. We do not allow any jewelry, and nails must be trimmed. Everything must be looked at in the OR staff. This is something very important, not to use cardboard boxes. The cardboard is a organic substance and that can invite insects and it has spores inside that, so everything should be replaced with the plastic buckets, plastic tubs, everything plastic is good. And scrub areas should not be forgotten from cleaning. Everything should be cleaned regularly with following a protocol. How to clean instruments may vary from place to place, but it is important to use soft water or RO purified water. And many of the ORs, they do have distillation plants. Distilled water is required for the last cleaning, last soaking, and it is also used for irrigation of different hollow bore instruments. Flushing with the air gun is important to dry the inside of these flushed items and then go for sterilization. Not enough to have a high-tech autoclave. It's very important that we understand the autoclave, how it functions. The staff needs to be trained properly, and bins are not recommended. This is something I learned way back at Aravind. Many of you, even Haripriya was not there, they may not know that Aravind had large number of these bins with poles around it. And when I think it was 1988 or 89, when infection control nurse came from the US and she worked with me. I learned with her how to make a OR protocol. Actually, that was my first protocol that I made with her. And first thing she did, and Dr. Nachia was really zapped, that she said all bins to be banned. They need to be thrown out. We do not need bins inside the OR. And Dr. Nachia had invested so much money on that, she was really not very happy that we told her to remove the bins. The packages should be in cloth. Now we know everyone makes packages in packaging. They do in cloth and not bins. On the packages, there should be name of the package, load number, signature of the on the chemical indicator that is put on that, and this should be a normal practice. We have kept in our institute expiry of autoclaved packs as 1 week. So whenever the date should show that 1 week has passed and the pack has still not been used, we normally send it for re-autoclaving. And we need to reject instruments which have debris or something. And we do have I forgot to put a picture. I learned that from Aravind actually, a box with a light inside that with which you can check whether the bottles have any particles inside that can be rejected. It's very important to check that the autoclaves are working. And there can be two types of cycles. But what's important, I already mentioned about the chemical indicator, which is just uh, on the package it will be there with the name, etc. TST strip is another one which we use, which here it is stuck here on in the register. There will be a round circle which will change color after autoclaving, and biological indicator. We test our autoclaves every day. The first load will have a biological indicator, which means that there is a filter paper inside this indicator which has organisms, live organisms. That's why it is biological. And the color changes after incubation if the organisms have not died. This is autoclaved along with the other items and then sent to the laboratory. We incubate that, and if it changes color, then autoclaving was not good. It did not happen. It should not change color and remain same after incubation, which means that the organisms have been killed. And this is the kind of incubator which comes from the company. It's 56 degrees centigrade. That's why a normal incubator will not work. We need to have a special incubator for that. And in autoclaves which have a vacuum creation inside them need to be tested for penetration of the steam at least once a month, and by using what is called Bavi dig method. This is the thing I have pasted here on the register. So once a month at least we do that to check that the steam is penetrating. Ethylene oxide gas sterilizers are monitored with the help of another biological indicator, not the same. And here it is red in color, and the incubation temperature is 37. So there is a difference. You cannot use the same biological indicator for both autoclave and the ethylene oxide. The sterile products need to be stored and transported properly, keeping in mind that they are not exposed to any contamination, and they should be really dry. Much has been learned. It took a long time for Indian hospitals to learn about segregation of biomedical waste. And thanks to, probably the one reason we can thank the COVID pandemic is all the hospitals have become very sensitive to this issue now. And then you find that they have learned, and the government agencies which are involved in helping the hospitals to do a proper segregation and disposal of biomedical waste has really improved. So every state is now active, and we must go by the rules and regulations of this particular activity. It is not only, I always tell them, it is not only the duty of the nurse to look at the labels when the surgery is starting on the packages. It is also doctors, especially if a doctor is mindful about that, then the nurse is going to be very careful about that, and always check all the relevant parameters on the labels which are there on the sterile packs. And that goes a long way. Realizing a mistake later is of no use. We must do it initially. Now, may I switch gears to surveillance in the OR? None of these protocols are going to happen unless there is a very robust surveillance system in the OR. Somebody has to be watching. We all work better, look better, behave better when somebody is watching. That's a human tendency. So we need to supervise, closely observe, and keep checking. And the idea is to improve awareness of the staff, let them know that we are checking. And we have a system where daily a team of two nurses who have a list of parameters to check, they make a round of the operation theater every day. And then they make a report which is presented to the Hospital Infection Control Committee. The idea is that the discipline is maintained in the OR. Everyone is under the knowledge that they are being watched. Now, when we come to microbiological surveillance, actually, I would like to ask David maybe later on after my talk what is done in the US. But in India, it is imperative to do microbiological surveillance. It is a legal requirement. Though if you read books, it says that microbiological surveillance is not required. A regular microbiological testing of the OR material or OR environment is actually not required. And I agree with that, because you need to do the cleaning and do the procedures and protocols rather than checking whether they are being done or not. But however, we do it, and we think it is important that whenever you start a new theater, you do it definitely when you have renovated, done some repair work in the OR, and to be done whenever there is an outbreak of post-operative infection in your OR. As I said, legally it is required, and since there are no guidelines, we have just decided on doing it once a month. And the material, there's no guideline what you should be collecting also. So we have made our own guideline of collecting swab from operation table, microscope handles, instrument trolley. People may object to, why do you want to test AC duct? AC duct is the area from where the air is going out, which is accessible to us. So I have put that in our list because I feel that they should clean that. And if you're collecting swab from that, they will definitely clean that, because that's something that can be neglected. And that will lead to cleaning of all other areas also. And the scrub water is also something we continue to test. There are fixed protocols for that, which will not go into detail, but a report is received in whatever test is done in the laboratory. The report is maintained inside the OR files. So it should be available. Even for NABH would like to see these reports, they must be maintained. Now, this is something we don't want to see. Any unusual or unexpected increase of a known hospital acquired infection is something we really dread. And in our case, we include endophthalmitis as well as surgical site infection for keeping a track of the infections that are happening in our institute. Our aim, of course, is to make it zero. We do have a HICC committee. I'm sure every hospital has or should have. And our instruction to all surgeons is whenever they have a suspected case of endophthalmitis, they must send one email immediately. And it should be addressed to the chairman, director, HICC chairman, HICC microbiologist, and operation room administrator, and the quality team. So everyone gets informed immediately, and the guideline is before 24 hours. Within 24 hours, the information must be just transmitted to everyone that there is one end of case. That's the form one that they have to fill up, which includes clinical details, staff details, and fluids and IOL and whatever has been used for the patient, all those details. And in secondary centers also, we have the same guideline is being followed in throughout the network. And then the people administrators have to call and refer the patient to nearest tertiary center from the secondary centers, and microbiological investigations are initiated. The primary surgeon later on will collect the microbiology details and other information and fill it up in the form number 2, and also make a summary and send it again to everyone. The administrators, everyone gets actually geared up to find out all details. They submit the OR surveillance reports. They recall all patients operated on the same day, and a meeting of all is organized within 48 hours. All people, they must meet. Nowadays, we are meeting online. Even with the secondary centers, we just have online meetings within 2 days of endophthalmitis happening. And the purpose of this meeting is to discuss the details of the case, check all related documentation, and discuss the surveillance reports and determine if there was any breach anywhere, and determine areas which may be requiring improvement. Now, none of these meetings are going to be helpful and complete unless there is proper documentation. So, most important for any of these investigations is documentation. And that is why the whole of surveillance system that we have in place is to make sure that there is documentation happening. You cannot investigate anything without documentation. And to me, the next word which is very important is traceability. What unless you document, you cannot trace. And what are we tracing? We have to trace the name of the patient, age, sex, address, everything. What are we tracing? Source of infection, and why are we tracing to stop more infections? We know that causes of postoperative infections are close to the eye. Microorganisms in the conjunctival sac, presence of organisms that can be very devastating on the instruments, hands, fluids, etc., or in the OR, or entry through the wound postoperatively. Now, how do we handle these? We are doing everything to handle each of these. So first one is, of course, we are doing cleaning the conjunctiva skin around, then using sterile items to handle the second one, HEPA filters for the third one, and teach hygiene to patient and proper instructions. We are giving antibiotics that we already discussed. Now, how do we find out what was wrong in that outbreak that happened? We have one of the things is CCTV is really helpful. Every OR table is covered with a CCTV, which gives us opportunity to look how the draping was done, how the cleaning was done, did they glove, scrub everything properly. Everything you can check with the help of the CCTV. Every case of endophthalmitis is the footage of the CCTV is seen by another person and not the same surgeon, another person, to check with everything was done properly. and check the techniques of assisting the surgery. The nurse and surgeon both are covered in the CCTV footages, and then you check all your other reports about the OR. This is just an example what happens in our OR. We have the patient record, which has all the information about which items were used for surgery. And then another register where those items can be traced for that particular patient, and when were those items sterilized, when were those items uh, given for surgery, and which autoclave was used, which gas sterilizer was used. Everything should be linked to the patient who had the endophthalmitis event. And when you can link that, only then you can approach other patients who were operated on the same day, and the similar items from the same autoclave were used for that patient. So that's how you trace everything that happened in one particular event. This is again the same thing, emphasizing that all information should be available in the EMR as well as in the records. So advantages of these investigations are we sometimes may not find the source, but everything gets reviewed again. Detection and tightening of the loopholes can happen, and this will increase the awareness of all concerned that we are not taking lying down any single event of endophthalmitis. Improvement in quality would happen, and it would prevent further post-operative infections. So therefore, all of us at every level should actually welcome the surveillance activities and adhere to the methods that are used for surveillance. With this, I thank you for your patient listening. Thank you.
Thank you, ma'am, for a very nice and elaborative talk on this topic, which is really, whenever we listen to your talk, we, keep adding a few things to, our own knowledge, and that really helps. You emphasized on so many good things that, we should have a proper protocol. Then you emphasize on the biomedical waste, which how COVID has made us more aware that about the biomedical waste, and that is so important. You very well mentioned about the documentation of everything. Like if anything goes wrong, proper documentation will help us trace where things went wrong. And you talked about the surveillance in the OT, and you talked about the microbiological surveillance. So you wanted to ask a question to David about the microbiological surveillance. So
Yes, yes.
yeah, David,
So
please.
congratulations. That was a wonderful overview, really comprehensive. I'm not actually aware of what our requirements are, in terms of testing. It's mostly about the autoclave, of course, working and things like that. So for ophthalmology, I'm not sure if it's required, and even, whether it's as widespread as, say, with orthopedic surgery or something like that.
Uh, Dr. Arup, would you like to say something on?
Yeah, I just wanted to ask, Madam, now every month is your recommendation for microbiological surveillance. Now, question of interpretation. Sometimes it comes as scanty growths. Sometimes it comes at some growth which is insignificant. How do you interpret it? How do you know
Yeah.
when it has to be taken seriously and which?
Actually, there are published articles about that. We do the settle plate method, which is keeping an 85 plate of Sabros dextrose agar for fungus and blood agar for bacteria. We keep it exposed for half an hour in the operating room table and then incubate it. So the break point or the upper limit of bacterial colonies is 10 colonies. That's been published in IGO long back by PGI Chandigarh group, and we adhere to that. So more up to 10 colonies, we are not worried. But if it is 15, 20 colonies, then we worry. And not even one fungal colony. There should be no fungus colony. So that's a guideline for fungus and bacteria. Uh, and for the swabs that we are taking from all sterile areas. So there should be no growth at all. And we in our OR, we are able to achieve that, no growth. But if there is growth, you only have to reprimand the people who are cleaning. And the solution, say, the usual difficulty we find is the housekeeping who is left to cleaning may not know to make the solution. We have to teach them how to measure. There should be a jar there to measure the solution. If it is 1%, this D125 is 1%. So 1 in 100. So in a bucket, how much of water is there and how much of D120? Because it is expensive. Now, if on their neck somebody is sitting, the administrator says you are using too much, then they will be very miserly in using, and they may not use the correct strength. So those are the important.
What is the significance of anaerobes? Sometimes we have nil culture from most of the places, but for 1 or 2 colonies of anaerobes. So how do you interpret that?
I really don't know, because anaerobic cultures are being done because it's a legal, again, it's a guideline. The some lawyer told me that in the law of court, they ask for anaerobic culture. That's why we use Robertson cooked meat medium. I really don't know. We don't get any time, but I think it has come from the earlier situations where tetanus used to be a post-operative infection in some of the ORs, surgery ORs. So probably that has remained in the in the law books from that time, and it is not of real big relevance for
So
ophthalmology.
we can disregard it
I
when
think so. I
such
think.
report comes.
Ma'am, is there any situation wherein you would like to say repeat or change this idea of 10 colonies? Like suppose we have 3, 4 end off in a particular on a particular day, and then after that you would like to check the sterility. So would you like to change anything, your criteria on that, or stick to that only?
No, no. First of all, why did the end off happened?
Yeah,
That has to be determined.
yeah.
It is most unlikely to have happened because your environment is having more than 10 colonies. The most
Hmm.
common causes we already saw
Fluid,
are close to the eye, the fluids and the
fluids. Yeah,
conjunctival sac.
yeah,
So we don't have to worry
yeah.
about changing those guidelines.
Ma'am, I have a question, ma'am, regarding supplies. Do you do routinely check all your consumables like BSS and viscoelastic? Do you check the pH and culture? And
We only check for the particles by shaking and looking against light. And this, I remember when Namrata had organized AIOS, there was a meeting about these post-operative infection guidelines, to develop guidelines. A very nice booklet has come out from that. We had agreed that microbiologists should not be burdened with checking the sterility of items which are already supposed to be sterile. They are the companies which are making, is their job to make a good product and make it sterile. Is not, because sometimes the microbiology testing may give you a wrong report, the way it is tested, and it is unnecessary burden for the microbiology labs. You may not get,
the
it's not.
only concern being it's when it is manufactured, they might have adhered to all the stringent needs, but during transportation, during storage, we know of so many stories of
Yeah, but the microbiology
contamination.
labs are not efficient enough to do that kind of checking.
So what do you do at Aravind, Haripriya?
Yeah, so we do check the culture and the pH for each batch of fluid and viscoelastic we use. We just for at least one sample per batch we
But
check.
have you ever found it contaminated?
Not so one is not the contact, but the pH. Sometimes we have had issues. So we see the pH may not be the adequate things, and then we return that batch and we get a fresh batch. In fact, recently we found something with the Contasol. I mean, so it's just that one batch could be an issue. We're not sure. We can't point a finger, but then we return the whole batch and we get a fresh batch because we use the batch for quite a long time. So we just want to ensure that it
Do
is.
you think it should become a standard protocol for all the private, all the hospitals?
Like Madam said, I'm not sure if it's easy and if it's possible, but if you have access and you can, then I mean, there's no harm doing anything more. I mean, doing less is not possible, but at least if you can do more, then to make it safer, it makes sense. Especially since we reuse the solutions and all that, so we have multiple patients involved. If either a bottle or a batch is not of optimum quality, so we believe in it.
One,
Any question? Yes, sir.
now one question to Dr. Savitri Sharma. Madam, this is regarding, you just made a passing reference to the OT cleaning with the different materials. Now, if the floor or the walls or roof is made up of stainless steel or vitrified tiles, you can use water and you can use disinfectants. But my question is, many of the modern theaters have only vinyl as the flooring and wall without any seams, without any borders. So, what is your protocol? What is your suggestion for cleaning those surfaces?
Vinyl, will it not withstand the normal disinfectants because they are not very strong? D125, the
No, we use
water bearing.
disinfectants, but we do not use detergents. We do not use
No, you don't need
water.
detergents. You use only disinfectants.
Only disinfectant.
Only disinfectant.
Yeah.
We use Lysol here.
Yeah, the Lysol also contains the same quaternary ammonium compound.
Yeah. On the vinyl floor.
I looked it up. When they were talking about COVID and they were discussing what should be used in the OPD and other huge areas, big corridors, it will be very, very expensive to use D125. They said we just cannot afford it. So we looked up Lysol. Lysol has the same quaternary ammonium compound. Yeah, you can use that. That's effective.
Another question about the RO plant, madam. For scrubbing, surgical scrubbing, we have many of us use the RO water, and for that there is a RO plant. Now you have multiple theaters. We need a pressure pump to have adequate supply for scrubbing.
Yes.
And that is only possible if you have a drum, RO water drum, very storage drum. So do you think it is a very sensible thing to do? Because most of the biomedical engineers, they say you have to have a drum, 100 liters or 500 liters capacity, and that will take care of all the pressure pump, whenever they have to pump the water into the taps.
I don't know the technicalities of those drum and other things, but as such, running water is always better than storing the water. But wherever the storage is, if it is mandatory and you really cannot do without storage, then that needs to be again taken care of.
Cleaned on a daily basis. We clean it on a daily basis.
Yeah.
Okay. Yeah.
When you
Dr. Malika, you want to say something?
Yeah. If for ethylene gas sterilization of any instruments, how long after they have been sterilized can they be used? Is there an aeration time they have to be allowed? And second question is, if it's a chemical or a drug that is being sterilized with ethylene gas, does it change their chemical composition? Because it is my feeling that if we ever try to do with silicone oil, it emulsifies faster than if you don't. So, Dr. Haripriya,
yes, it might. And actually, if you read the brochure of the ethylene oxide sterilizer, liquids are not supposed to be sterilized in that, because the gas has to pass through whatever item is being sterilized. So where is the question of gas passing through that liquid? It will not.
Is there an aeration time you require before you can use the instrument?
Yeah, that depends on the machine. When we had earlier machines, the older machines, it will say in the brochure how many hours. So it had 16 hours. It was a very, very long time. Now, but the current machines are much better. They are very good, and the aeration time is built inside the whole cycle. So it comes out with, can be used immediately. It depends on what kind of machine you have.
Okay. Thank you,